So let's look at the role of his Purkinje system in arrhythmogenesis today. Almost everyone would be aware of this phenomenon where the H1 and H1H2, there's a dramatic cycle length change that can be a block, which is a physiological type of block. The Purkinje system does not like switches in cycle length too quickly. It doesn't adapt. It anticipates a fixed cycle length or very minor infringement of that. And whenever there are wild fluctuations, it tends to block. And this is not pathological, even though there is a his H1 here, H1 here, this H2 with a normal AH interval, but blocks because the H1 was previously 800. It was expecting it somewhere here, and when the interval comes rather abruptly, it tends to block compared to previously the same block occurred. So this is very characteristic of this. This his to this is followed. The HH fluctuation can produce physiological blocks. You can see his HPS physiology in different ways. So here is HH, again a drivetrain of 700 followed by 410, and as you can see at 310 the AH lengthens 390. At 370 there is AH is fixed but the HV starts lengthening, and at 350 there is an infra-His block. The question, as you can see, this is the infra-His block. The question is this physiological or not? So HPS abnormalities are typically HV interval greater than 55 milliseconds is considered abnormal, but not profoundly pathological that dictates placement of a pacemaker. When you have an HPS block at cycle lengths greater than 500 milliseconds is considered pathological. ERP of 450 milliseconds, greater than 450, that does not resolve with faster drivetrain, or HV increase with greater than 100 milliseconds with a class 1 agent. So it all considered. In this case, it was 700 over 350. So if you shorten the drivetrain to 600, it'll start conducting, so this is a physiological type of block. On the other hand, a fixed atrial pacing at 700 milliseconds, here is atrial pacing from high right atrium from a halo catheter, AH interval with a right bundle branch block pattern, a left bundle branch block pattern, AH is fixed but HV is prolonged, and then you get a complete block with AH and no V. And so the interesting thing, the immediate thing that needs to be measured is what happens to the HH interval. Here's a His to His interval, and here's a His to His interval. There's no change, and then you get a block. This is at a fixed drivetrain. This is truly pathological blocking at 700 milliseconds infra-His with alternating bundle branch block, a classic indication for putting a pacemaker. So the retrograde right bundle branch block also as part of the Purkinje physiology. You can see V, His, and this is the His. This is the local far field V, and then you get an A, and then you see the retrograde right bundle branch block pushes the His out, and then you get an A, which is suggestive that all conduction is Purkinje dependent or AV node dependent. It is not an accessory pathway. So this excludes the presence of an accessory pathway. And this is because you have a retrograde right bundle branch block. There's a period of transeptal conduction apically and ascending up on the left bundle, which shifts the His from the stimulus to the His increases, you can see this His signal increases out, and then you get a same fixed HA interval, which is the so-called binaural and fast pathway conduction. In ventricular tachycardia, if you have short, long, short, that way the His-Purkinje system and the myocardium refractory periods can be separated and myocardial reentry can be facilitated. Now, His-Purkinje system can also be the source of automatic VT, especially if the initial beat is exactly the same as subsequent morphology VT. Then it is either most likely a triggered kind of a VT or focal VT rather than something that's reentry. So the initiating beat is the same as a subsequent considerable or triggered activity. And here in this patient, you find this kind of a potential. And if you can ablate this, the difference between fascicular potential and Purkinje potential, Purkinje potential does not have an isoelectric line because it's a part of the myocardium unit itself. Whereas when you have His, for example, it's a kind of a fascicular potential. You have a long isoelectric line before you get to V. So that is very suggestive that that is a fascicular potential, but in this case, this is a Purkinje potential because there's no or triggered activity. And here in this patient, you find this kind of a potential. And if you can ablate this, the difference between fascicular potential and Purkinje potential, Purkinje potential does not have an isoelectric line because it's a part of the myocardium unit itself. Whereas when you have His, for example, it's a kind of a fascicular potential. You have a long isoelectric line before you get to V. So that is very suggestive that that is a fascicular potential, but in this case, this is a Purkinje potential because there's no, you can see that this would conduct back to the His while it's conducting to the ventricle. So this way, the HV interval will be a pseudo interval, and it will be a little bit shorter than the regular interval in terms. So we need to understand that the VTs are rising in the left posterior anterior fascicular bench reentry VT. And here on the side, I've given the velocities of conduction. You can see that the Purkinje tissue is 80 times faster than the AV node or on the myocardium. It is quite fast compared to what the myocardium can do horizontally, particularly. So you can see, compared to the AV node, definitely the Purkinje is quite faster. For bundle branch reentry, PPI TCL, as I mentioned earlier, is shorter from the ventricle apex because of the turnaround point. So here is a fascicular VT. As you can see, there again, the fascicular potential here on the His is getting passively activated. You can see the same potential in the ablation catheter. The potential is occurring in the middle of the QRS, and that's very, very interesting. That is just fascicular VT. You can see that this would conduct back to the His while it's conducting to the ventricle. So this way, the HV interval will be a pseudo interval, and it will be a little bit shorter than the regular interval in terms. So we need to understand that the VTs are rising in the left posterior anterior fascicle will have a different HV interval. So here I have marked a case where the HV interval is shorter at the His-Purkinje level compared to where the fascicle where the VT is. And you can see here, this is truly a fascicular potential. There's a nice isoelectric line, and that component end where there's no isoelectric line is a Purkinje in his fascicle to Purkinje interface. And so the Purkinje potential does not have an interval between does not have an isoelectric line between the potential and the local ventricular activation, whereas the fascicle itself has a nice isoelectric line that is very easily discernible. You can also see that the HV is a pseudo interval, and that's why this is an upper septal VT. As QRS and H are simultaneous. So here you can see if you put the catheter at this location, the fascicular potential to V interval will be equal to sinus rhythm versus PVC. The potential to the ventricular electrogram will be equal if you are at the exact location of the origin of tachycardia. So I have an HV interval during VT. If it is greater than or equal to sinus rhythm bundle branch VT, if it's equal to bundle branch VT or SVT with aberrancy. If you have HV interval VT less than in sinus rhythm, then you have fascicular potential to VT is equal to fascicular potential to the QRS and sinus rhythm. Then you're dealing with upper septal VT. But if you are not equal to, then you're dealing with some form of fascicular VT, in which case you have to localize mid-diastolic potential and look at the Purkinje potential to mid-diastolic potential relationship as a way of ablating this. So here is a different form of his Purkinje disorder, where a PVC triggers polymorphic VT, and when we take the patient to the lab, we have the same issue of lots of potentials which are driving the obvious polymorphic VT here, and this is the idiopathic. So this is a clearly somewhat at the fascicular level, not at the Purkinje level, leading to polymorphic VT, and a focal source of ablation will eliminate this ventricular tachycardia. So I have covered most of the physiology and his Purkinje system in disease at various levels. We will look at VT in structural heart disease at a later date. Thank you for listening.